Welcome to The Explainer. Today we are diving into a really fascinating question, one that brings together medicine, dentistry, and how kids grow up. And the question is this: can the simple act of breathing actually change the shape of a child's face?
It really does sound like something out of science fiction, right? But, for more than 100 years, doctors and orthodontists have been pretty convinced that the answer is a big yes. The whole idea is that if a child is always breathing through their mouth, usually because of something like big tonsils, it can lead to a really specific look.
And that look has a name. It's called the adenoid face. You can see the characteristics right here. We're talking about a longer face, that classic open mouth look, dark circles under the eyes, and then a whole bunch of dental stuff, like really crowded teeth and a high, narrow roof of the mouth. It's a look that a lot of clinicians say they can spot from clear across a room.
So how in the world could this happen? Well, the theory behind it is actually surprisingly simple, and it's been built up over a century of just watching and researching kids as they grow. It really all comes down to the gentle but constant forces that are always at work shaping a child's face.
This idea actually goes way, way back to 1872, but it really started to get scientific legs with a couple of key moments. First, in 1969, you have the functional matrix theory, which basically said that function shapes form. How we use our face determines how it grows. Then, in 1981, there was this famous experiment with monkeys that seemed to prove it all. The monkeys that were made to breathe through their mouths developed longer faces. For decades, that was pretty much case closed. But in the last few years, the story's gotten a whole lot more complicated.
Okay, so the big idea behind all of this is that functional matrix theory. It basically says that when a kid breathes normally, through their nose, their tongue rests up against the roof of their mouth and their lips are together. This creates this perfect balance of forces. The tongue pushes out and the cheeks and lips push in. And that balance is what guides the upper jaw to grow nice and wide and forward. But the second a child has to start breathing through their mouth, that whole elegant system just gets thrown completely out of whack.
And here you can really see what we're talking about. The tongue drops down to let air in, the mouth just kind of hangs open, and poof, those balanced forces are gone. The theory goes that without the tongue holding things in place, the cheeks can start to squeeze inward, making the upper jaw narrower. And that constant open mouth position lets the lower jaw just drop down and back, which encourages the face to grow longer and more vertically. It's like a domino effect, all started by just changing the path of the air.
But here's the thing. This goes way beyond just how someone looks. The root cause of all this mouth breathing, those enlarged tonsils and adenoids, is connected to some really serious health issues. We're talking about things like obstructive sleep apnea, which can mess with growth, lead to behavior problems that look a lot like ADHD, and even increase the risk for cavities because the mouth is always dry. So the stakes for a child's overall health are actually really, really high.
So for a really long time, the story was simple, right? Big tonsils lead to mouth breathing, which leads to the adenoid face and other health problems. Case closed. But in the world of evidence-based medicine, you can't just leave it at that. Eventually, researchers decided to pull all the studies together to see just how solid this connection really was. And that's when things got a little fuzzy.
This quote from a huge recent review of all the data really nails the new debate. They looked at information from over 8,000 kids and, yep, they confirmed it. There are real, measurable differences between mouth breathers and nose breathers. The differences were there, but they were also pretty small. So small that it raised this massive question: do these little differences actually matter in the real world?
To make this real, let's put a number on it. The big analysis looked at a key measurement that orthodontists use to see how vertically a face is growing, and they found that the average difference between mouth-breathing kids and nasal-breathing kids was just 2.2 degrees. Now that difference is real, it's not a fluke, but it makes you wonder, is 2.2 degrees really enough to create that dramatic adenoid face? Is that a difference you or I or even a doctor would reliably notice just by looking at someone?
And this, right here, brings us to the absolute heart of this whole explainer. How can something be statistically significant, but at the same time maybe not clinically significant? It sounds like a total contradiction, but it is one of the most important ideas to grasp if you want to understand modern medical research.
Okay, let's break this down. Statistical significance. That's the one you always hear about, the p-value. All that means is that the result you found probably isn't just a random accident. And if you have a massive study with thousands of people, even a teeny tiny difference can be statistically significant. But clinical significance, that asks a way more practical question. It asks, is this difference big enough to actually matter to a person? Does it change how they look, how they feel, how they function?
Is it big enough to say, okay, we need to do something about this?
So let's go back to that 2.2-degree difference. We can now see it in a new light. That difference is statistically real. It's not a fluke, but it might not be clinically meaningful. It might not be big enough on its own to be the smoking gun for a major orthodontic issue, or to justify a surgery just to change how a face is growing. And understanding that difference is at the core of this whole debate.
So if the effect is real, but kinda small, does that just mean we shouldn't worry about it? Well, not exactly, because there's another massive piece to this puzzle, and that's timing. A kid's face doesn't grow evenly all at once. Different parts hit their growth spurts at totally different times.
This graph is so important for understanding this. Just look at the blue line. That's the part of the skull that holds the brain. It's almost totally done growing by the time a kid is about 7. But now look at the red and green lines. That's the upper and lower jaw. They have this much longer, slower burn, and they keep growing well into the teenage years.
And this table just makes that even clearer. At age 5, a kid's lower jaw might only be about 75% grown. It has years and years of growth still to go. Now, what that means is that a small negative push from something like mouth breathing, if it's happening day in and day out, over all those critical growth years, could add up over time and become a much bigger clinical problem. And that's why everyone agrees that catching it early is so critical.
Okay, so this all leads us to the big practical question. What do we do about it? Given everything we've talked about, what treatments actually have the strongest proof behind them?
Well, when we look at the surgery to take out adenoids and tonsils, the evidence is crystal clear on a few things. It is fantastic at fixing sleep apnea. It helps kids who are struggling with growth to have a catch-up spurt, and it makes a real difference in behavior and quality of life. Those benefits are proven, and they are absolutely clinically significant. But the effect on how the face grows, well, that's still in the debated pile. Some studies show it helps, but the effect isn't always big, and it's not consistent across every single study.
Ultimately, what this all points to is that this isn't a job for just one kind of doctor. The best way to handle this is with a team. You need an ENT specialist for the airway, a pediatrician watching over their general health, and an orthodontist to manage how the teeth and jaws are developing. Getting everyone involved early allows the team to tackle the proven problems, like sleep apnea, while keeping a close eye on the debated ones, like facial growth.
So let's circle all the way back to where we started. Can how you breathe actually change your face? Well, the simple yes that we had for about 100 years has gotten a lot more nuanced. Today, a much better answer would be, yes, it looks like it has a real, measurable effect, but that effect might not be as big or as dramatic as the old-school adenoid face idea would have you believe.
And that's what makes this topic so cool. It's not really just about faces and breathing, it's the perfect example of how modern, evidence-based medicine works. It teaches us to ask not just, is there a difference, but to follow it up with, is that difference big enough to really matter? And learning to apply that filter is the key to making better health decisions. So the next time you hear about a new study, you'll know that the most important question to ask isn't just if it's true, but if it truly matters